हेलो रामकृष्णा जी। डॉक्टर रामकृष्णा।
नरेश भाई।
रामकृष्णा जी, some user is doing some scratch means. So how to prevent that person or uh,
उसको निकाल देना सर।
yeah, can we block through the
नेक्स्ट
to
टाइम
make
चेक करते सर।
reactions from other people?
सेटिंग्स में देखना सर, होस्ट टूल्स। ओके, शेयर नोट्स। इसमें नहीं है सर, कंप्यूटर में रहता सर, मैं देख लेता सर।
Okay, okay.
रिकॉर्ड करना है सर।
That moderator is having some login issue. BBC 2025 क्या है password? BBC
पासवर्ड सेम है
2025.
ना।
Hmm.
देखो,
Yesterday
आपको
also,
मैं होस्ट कर रहा हूँ।
yesterday also he joined late.
वो वेरीफाइड अकाउंट हुआ तो कोई प्रॉब्लम नहीं रहता सर। जस्ट
हाँ हाँ.
ऐप विदाउट रजिस्ट्रेशन ये डिफिकल्टीज होता।
Yeah,
राइट सर, कैरियर।
yeah. Yeah, sir has joined. Take after Pasha sir is
Yeah, yeah.
today's moderator.
Sorry, man. It's pretty.
No problem.
Please start. Go ahead. Thank you.
Yeah, today's moderator is Dr. Take after Pasha. Sir is having more than 15 years of experience. And today, Dr. Ramanan is presenting on cerebellar system. So, sir, you can introduce yourself, followed by Dr. Ramanan, then we can start.
Okay, okay. Myself, Dr. Sheikh Afsar Pasha. I did neurology from NIMHANS in 2011. I worked as an assistant and associate prof in NR Medical College, professor of neurology in NR Medical College, and practicing as a consultant neurologist in Ashraf Neuro Hospital in Vijayawada. Oh, okay. Thank you. Go ahead.
Good evening, everyone. Good evening, sir. I am Dr. Ramanan. I am a DRNB resident, third year resident from Indira Gandhi Government General Hospital and Postgraduate Institute, Pondicherry. I shall start with my slides, sir.
Yeah, okay, go ahead.
Yes, sir.
Yeah, please go ahead.
Starting with anatomy, the cerebellum is located in the posterior fossa beneath the tentorium cerebelli, below and anteriorly. It is separated from the dorsal pons by the fourth ventricle and from the medulla and dura mater covering the atlanto-occipital membrane by the cisterna magna. Grossly, there are three parts: the cerebellar hemispheres, the vermis, and flocconodular lobe. The cerebellar hemispheres are two larger lateral masses. The vermis is a small, unpaired median portion that connects the hemispheres. The flocconodular lobe is a small midline structure that lies on the anterior part of the inferior surface. The flocconodular lobe consists of the paired lateral flocculi and the midline nodulus. The vermis is separated from the hemisphere by parameridian sulci. The cerebellar tonsils are small, rounded lobules on the inferior aspect of the cerebellar hemispheres, just above the foramen magnum. These are the lobules of cerebellum. The vermis again consist of 9 parts like lingula, central lobule, pulmon, declive, tuber vermis, folium vermis, pyramis, and uvula. And hemispheres again has 8 lobules like frenulum, ala, quadrangular lobule, lobus simplex, superior semilunar lobule, inferior semilunar lobule, biventral lobule, tonsils. And vestibulocerebellum or archicerebellum contain nodulus and flocculus. These are actually less important clinically. This is human body representation in cerebellum, where the head is represented midline and limbs are represented in the peripheral cerebellar hemispheres. Coming to anatomical classification, anterior lobe, posterior lobe, and flocconodular lobe. The deep transverse primary fissure divides the cerebellum into anterior and posterior lobes, and the posterolateral fissure separates the flocconodular lobe from the posterior lobe. Afferent connection-wise classification, and it is divided as vermian, paravermian, and lateral. Basically, we use this system for the clinical localization. Functional classification. Functionally, cerebellum is divided into 3 divisions: vestibulocerebellum, spinocerebellum, and corticocerebellum. In vestibulocerebellum, it includes the flocconodular lobe, which is its principal component and has vestibular connections only. Nucleus vestigial is its effector nucleus. It receives input from ipsilateral vestibular nuclei, pretectal area of midbrain, and visual cortex. It is concerned with control of body posture and equilibrium. From spinocerebellum, it includes the parts forming paliocerebellum, that is entire anterior lobe except lingula, and some parts of posterior lobe like pyramid, uvula, and parafolliculus. Nucleus interpositus, that is nucleus globosus and nucleus emboliformis together called, are its effector nuclei. It receives proprioceptive inputs from the trigeminal nucleus and dorsal column of spinal cord. It is concerned with control of axial and limb muscle postural reflexes. Corticocerebellum is also called as central cerebellum. It includes whole of the posterior lobe except pyramid and uvula. Its effector nucleus is dentate nucleus. It receives input from ipsilateral primary and supplementary motor cortex and the contralateral inferior olivary nucleus. It is concerned with smooth performance of highly skilled voluntary movements. Phylogenetic classification. Phylogenetically, that is, according to evolutionary stages, the cerebellum consists of 3 subdivisions. Archicerebellum, which is the oldest part to develop, it consists of flocconodular lobe and lingula. Flocconodular lobe is involved in eye movement control and gross orientation in space, such as up and down. Paliocerebellum is the next part to appear. It consists of entire anterior lobe except lingula and following parts of posterior lobe like pyramis, uvula, and paraflocculus. It is involved in posture maintenance, muscle tone, axial muscle control, and locomotion. Neocerebellum is the last or latest part to develop. It consists of whole of the posterior lobe except pyramis and uvula. It is involved in coordinating movement and providing fine motor control for precise movements of the extremities. Afferent and efferent pathways of cerebellum. There are 3 peduncles: superior cerebellar peduncle, middle cerebellar peduncle, and inferior cerebellar peduncle. In superior cerebellar peduncle, the major afferent tracts are anterior spinocerebellar tract and tectocerebellar tract. And the principal efferent tracts are cerebellorubral, dentatothalamic, dentato-olivary, vestigio-reticular. In this, the very important tract is dentatorubro-thalamic tract. Next, in middle cerebellar tract, which is has only afferent tracts, that is corticopontocerebellar pathway. Inferior cerebellar peduncle has majority afferent tracts like posterior spinocerebellar, cuniocerebellar, olivocerebellar, or olivocerebellar, reticulocerebellar, vestibulocerebellar, anterior external arcuate fibers, stria medullaris, and trigeminocerebellar. The efferent tracts are cerebellovestibular, cerebello-olivary, and cerebello-reticular. Histological structure. Histologically, cerebellum consists of cerebellar cortex, white matter, and deep cerebellar nuclei. Coming to cerebellar cortex, the cortex is made up of three layers: the outer nuclear or molecular layer, the layer of Purkinje cells, the inner or granular layer. These are the composition of each layers. The molecular layer contains basket cells, stellate cells. Purkinje layer contains Purkinje cells and Bergman glial cells. Granular layer contains granule cells, Golgi cells, and brush cells. This is the histological diagram of the above explanations. Coming to sensory inputs to cerebellar cortex, the cerebellar cortex receives sensory inputs from other parts of the brain by two types of sensory fibers: the climbing fibers and mossy fibers. Both set of fiber reach the cerebellum through peduncles and are excitatory in nature. Climbing fibers arise from neurons of the inferior olivary nucleus situated in medulla and reach the cerebellum via olivocerebellar tract. Climbing fibers establish one-to-one connection with Purkinje cell dendrites and excite them to discharge. Collaterals of climbing fiber synapse with all other type of neurons in cerebellar cortex and also deep cerebellar nuclei. Mossy fiber, it is unlike climbing fiber. The mossy fiber has many sources of origin. These are axons of spinocerebellar, vestibulocerebellar, reticulocerebellar, cuniocerebellar, and corticopontocerebellar tracts. Mossy fibers are named so because they resemble the moss plant. Each mossy fiber makes synaptic connection with dendrites of many granule cells, forming synaptic glomeruli. The glomeruli also contain the inhibitory ending of Golgi cells. Each mossy fiber activates about 450 Purkinje cells through the granule cells and their parallel fibers. Thus, a climbing fiber excites a single Purkinje cell, whereas a mossy fiber through granule cells and parallel fibers excites several thousand Purkinje cells. Both climbing and mossy fibers of sensory inputs exert excitatory influence. Out of 5 types of neurons in cerebellar cortex, only the granule cell is excitatory, that it releases excitatory neurotransmitter glutamate. The other 4 types of neurons are inhibitory and release inhibitory neurotransmitter GABAergic. So this is the sketch representation of the above explanation. From cerebellar cortex, the information reaches pons. From there, through mossy fiber, it reaches the contralateral granular cells, which is present in the granular layer of cerebellar cortex. From there, through parallel fibers, it reaches the molecular layer, where basket cells and stellate interneurons are present. In molecular layer, the parallel fiber bifurcate and form T-shaped branches. From there, it again descends to reach the Purkinje layer to reach and stimulate the Purkinje cells. Also, the basket cells directly inhibit the Purkinje cells, and stellate interneurons can inhibit the Purkinje cells. So the Purkinje cells output is also inhibitory. So they are GABAergic output, which will inhibit the deep cerebellar nuclei. So this is mossy fiber, which has afferents from so many tracts. Climbing fiber, which has afferent only from inferior olive, directly reaches the Purkinje cells, and they can also stimulate the deep cerebellar nuclei. White matter core, projection fiber of the they leave the cerebellum or enter the cerebellum and connect it with other parts of the central nervous system. They are arranged in 3 bundles, which are superior, middle, and inferior cerebellar peduncle. Association fiber connect different regions of same cerebellar hemisphere. Commissural fiber connect the areas of 2 halves of cerebellar cortex with each other. Deep cerebellar nuclei. The cerebellum is made up of white matter core covered with a thin layer of gray matter, the cerebellar cortex. Deep in the white matter are several gray masses, the cerebellar nuclei. The dentate nuclei, the largest of the cerebellar nuclei, are gray matter structure situated deep in the white matter of each hemisphere. In the hilus of each dentate nucleus lie the emboliform nuclei. Medial to the emboliform are the globose nuclei. The globose and emboliform nuclei together are called as nucleus interpositus. In the white matter of the vermis, at the roof of the fourth ventricle are the vestigial or roof nuclei. So from lateral to medial, the deep nuclei are arranged in DEGF pattern, that is dentate, emboliformis, globose, and vestigial. So this is the diagrammatic representation of the deep cerebellar nuclei. We could see the vestigial nuclei in the medial aspect, following globose nucleus and emboliform nucleus, and most laterally we have the dentate nucleus. So neural circuits and neuronal activity in cerebellum. Cerebellum executes its function through excitatory output of the deep cerebellar nuclei to the brainstem and thalamus. Neural connections within the cerebellar cortex, that is, intrinsic cerebellar circuit, is basically concerned with modulating or timing the excitatory output of deep cerebellar nucleus via the fibers of Purkinje cells. This is done in accordance with signals received by the cerebellar cortex from different parts of the brain and body. The entire process can be discussed for the purpose of understanding only in the following headings. Afferents to cerebellar cortex, neuronal activity of intrinsic cerebellar circuitry, and neuronal activity of deep cerebellar nuclei. So afferents to cerebellar cortex, these are climbing fibers and mossy fibers. I am not detailing it again as I have discussed before. Neural activity of intrinsic cerebellar circuitry. As a result of excitatory input from the climbing fibers or mossy fiber, following activity is set up in intrinsic cerebellar circuitry. So we have 4 types basically. One is feed-forward inhibition of Purkinje cells. Here, the mossy fiber will stimulate the granule cell. The granule cell will stimulate through parallel fibers the Purkinje cells. So the output is excitatory. But this excitation is extremely short-lasting because the mossy fiber which stimulate the granule cell through parallel fiber, which also stimulate the basket and stellate cells. But the basket and stellate cells output is inhibitory. So this will inhibit the Purkinje cells. So this mechanism helps to limit the duration of excitation produced by given afferent impulses. Otherwise, it sharpens the timing of Purkinje cell firing. Feed-forward inhibition of granule cells. Similarly, mossy fibers excites granule cells. Again, this excitation is again short-lasting because mossy fiber will also excite Golgi cell. Golgi cell's output is inhibitory, so this Golgi cell will in turn inhibit the granule cells. This mechanism prevents excessive granule cell activation. Feedback inhibition of granule cells. Granule cells through parallel fibers stimulate Golgi cells. Golgi cell in turn will inhibit the granule cells. So the granule cell ultimately results in its inhibition. So this is called feedback inhibition of granule cells. So this mechanism stops granule cells after a short burst. Next, the reverberating circuit. The granule cells and Purkinje cells form a reverberating circuit. The main function of reverberating circuit is to revive and strengthen the non-functional synapses when 2 neurons discharge by repeatedly and synchronously. Suppose a person is making an alternative supination and pronation of his hand rhythmically. This is made possible by the reverberating circuit. Next, moving on to the blood supply of cerebellum. So cerebellum is basically supplied by superior cerebellar artery, anterior inferior cerebellar artery, and posterior inferior cerebellar artery. The superior cerebellar artery supplies the superior half of the cerebellum. The anterior inferior cerebellar artery supplies the anterior part of the inferior surface of the cerebellum. The posterior inferior cerebellar artery supplies the posterior part of the inferior surface of the cerebellum. So this is the radiological image. Here we could, in sagittal view, we can easily explain the blood supply. So the superior cerebellar artery is entirely supplying the superior half of the cerebellum. The anterior inferior cerebellar artery supplies the anterior part of the inferior surface of the cerebellum, and the posterior inferior cerebellar artery supplies the posterior part of the inferior surface of the cerebellum. So the superior cerebellar artery originates from the terminal end of basilar artery. It supplies the superior cerebellar surface of the cerebellum, also upper vermis, nuclei, much of the white matter tracts. Anterior inferior cerebellar artery originates from basilar artery just above pica, supplies the anteroinferior cerebellum, flocconodular lobe, and middle cerebellar peduncle. Pica originates from vertebral artery, supplies posterior inferior cerebellum, lower nervous, and nucleus. The vascular supply is mainly important in terms of posterior circulation strokes. Arterial territory infarct causing acute ataxia, pica territory, ica territory, and superior cerebellar artery territory. Also, in ataxic hemiparesis, superior branch of ACA, which involve the frontopontocerebellar fibers, corona radiata, posterior limb of internal capsule, basis pontus, all can lead to contralateral ataxic hemiparesis. Coming to clinical discussion, cerebellar symptoms I have organized in a head-to-foot manner. So, coming from above, cerebellar symptoms can have titubation, that is head tremors, which is usually anteroposterior tremor. Visual disturbances or oscillopsia or involuntary eye movements. Next, slurring of speech, that can be scanning staccato dysarthria. Patient in which patient will give impetus to each consonants of the word, and they will break the word into individual syllables, and in staccato they will have an explosive end. Patients with cerebellar dysarthria can have either scanning dysarthria alone or scanning staccato dysarthria. Then in sitting, standing, and gait, they can have ataxia, which we will call as truncal ataxia. Then clumsiness or tremulousness of hands. Then hypotonia. This is due to lack of gamma motor neuron facilitation by the cerebellum. Then cognitive disturbances. These are subtle because these are subtle complaints, sometimes may not be told by the patients, and we can find out during examination alone. Because posterior vermis is involved in cognition. Cerebellum signs, titubation. So again, SCS type or anteroposterior type. In eyes, we can have gaze-evoked nystagmus, Brunn's nystagmus, periodic alternating nystagmus, and downbeating nystagmus. Gaze-evoked nystagmus is seen in many types of cerebellar issues. Brunn's nystagmus is commonly seen in CP angle lesions, where we will have ipsilateral cerebellar type of ataxia or coarse ataxia, or the contralateral vestibular ataxia or cerebellar nystagmus or coarse nystagmus, and contralaterally we will have vestibular or fine nystagmus. Periodic alternating nystagmus is usually seen in lesions involving the flocconodular lobe. Downbeating nystagmus is usually seen in craniocervical junction issues. Hypo or hypermetric saccades, impaired vertical saccades, saccadic pursuits, slow saccades, which is called as Vadia sign, which is classically seen in SCAR2, oculomotor apraxia, where patient, when asked to turn their eyes, initially gives a blink followed by head turn. Subsequently, they will have the eye deviation. Classically seen in oculomotor apraxia type 1 to 4, can also be seen in ataxia telangiectasia. Square wave jerks, classically seen in Friedreich's ataxia, where there will be horizontal saccadic intrusions with intersaccadic interval. I have video for square wave jerks and slow saccades. Subsequently, I'm showing that. And ophthalmoplegia and ptosis and maculopathy. Ophthalmoplegia and ptosis can be seen in mitochondrial disorders, in Sandow. Maculopathy is seen specifically in SCA7, which is ATCA type 2. Again, eye movement abnormalities and ataxia. Engaged nystagmus are seen in many types of ataxia. Downbeat nystagmus is seen in EA2, SCA6, and craniocervical junction disorders. Saccadic pursuits are seen in SCA3. Hypo or hypermetric saccades are seen in many types of ataxia. Slow saccades, Vadia sign, classically seen in type 2, but can also be seen in 1, 2, 3, 7, 17, 23, 28, and apraxia with oculomotor apraxia. Impaired vertical saccades are seen in Niemann-Pick type C, SCA37 and 40. Square wave jerks are seen in Friedreich's ataxia. Oculomotor apraxia is seen in oculomotor apraxia with oculomotor apraxia types and ataxia telangiectasia. Ophthalmoplegia and ophthalmoparesis seen in Sandow, SCA1 and SCA3. Ptosis is again seen in Sandow and mitochondrial ataxia. Maculopathy is specifically seen in SCAR7. Next, coming to dysarthria, it can be of scanning or scanning staccato speech. Next, in dysmetria, we can have finger nose test impairment and heel nation test impairment. This is due to asynchrony in the rate, range, and force of a movement. Then patient can have intentional tremor. That is, while approaching the target, they will have increased clumsiness. Dysdiadochokinesia, defective alternating movement. Rebound phenomena, it is due to impact check response of the antagonist muscle. Hypotonia, it is due to loss of gamma motor neuron facilitatory drive. Occurs only in acute condition. In chronic condition, it is compensated. And there can be truncal ataxia, stance ataxia, and gait ataxia. Now, localizing each titubation is predominantly seen in midline structures like vermis and paravermis. Eye signs are seen in both vermis, paravermis, and cerebellar hemispheres. The midline, the impaired vertical structures are due to midline structures. The downbeat nystagmus is due to midline structure. And dysarthria is due to paravermian area, predominantly involving the left side. Dysmetria, intentional tremor, dysdiadochokinesia, rebound phenomenon, all are due to cerebellar hemisphere issues. Truncal ataxia, stance ataxia, and gait ataxia is due to vermis. So I'm showing few videos for signs. So this is intentional tremor. While approaching the hand, patient is having increased clumsiness.
Ramanan, describe.
Yes, sir.
Describe what you're seeing in
yes.
the video.
Yes, sir. Yes, sir. Patient now does the finger nose test with the right and left hand. While approaching the examiner's finger, there is increased clumsiness and patient over or undershoots the finger.
Just
Now we can see in
remove your cursor,
patient
please.
has some.
Dr. Ramanan,
Yes,
Ramanan,
sir.
please remove your cursor.
Yes. Yes.
The thing is, when we record the video, we should the examiner's finger, it should be away from the at least a full arm length. Okay, you are putting the finger very
Okay,
close, very close. Okay, and hand should be completely extended.
Okay, sir.
Okay, and it should be rapid. It
Yes,
should
sir.
be
Yes.
rapid. It is very slow.
Okay.
And one more thing is,
Okay,
please replay the video. I'm sorry to say that it's there is no classical intention. When trying to reach to the target, there should be jerkiness of the. For which you need to, what you should do is like you abducted the shoulder, and this hand should be completely
Okay, sir.
extended, and the examiner's finger should be swiftly changed from direction to this way and that way. It is fixed.
Okay, sir. Okay, sir.
I don't know. Dr. Shailesh, can you see that intentional goal-directed activity tremor? What he's trying to say? Dr. Shailesh.
Yes, sir. Sometimes in Zoom, there will be some no much clarity. You have to check the
Maybe
original
that
image.
might be the patient might be having. Dr. Ramanan, don't mind. I'm telling like this. The correct way of recording is
Yes, sir.
the finger should be at a distance of full arm length, and arm should be abducted, and should be examiner's finger should be swiftly changed from direction to direction like this. Okay. And the classical what
we
I'm
have
trying
to
to show
change
is
the
on
target.
goal directed activity, there is a tremor which is brought out, which is classical, the sine qua non sign of cerebellar disease. If it is on right side, if you are getting right side cerebellar outflow tract tremor, this is what we call right cerebellar outflow tract tremor, right? And if you are getting on the left, it is the left cerebellar outflow tract tremor, intentional tremor. Okay, go ahead.
Yes. Next, this is a video of wing beating tremor. He is a patient of Wilson's disease. It is due to dentatorubrophthalmic tract involvement or red nucleus or thalamus. In wing beating tremor, there will be involvement of proximal and distal component, and it is present during rest and action intentional.
It is not at
Post check,
rest.
sir.
You are asking the patient to do an action, right? You are asking the patient to outstretch the
Yes, sir.
limb and putting the hands across in front of the chest. It is an action. It is not at rest. Rest is like arms
Yes, sir.
supporting on the thighs. That is called rest. This is an action tremor. You are asking the
Yes,
patient
sir.
to do an action. And hands
Yes, sir.
putting across the chest, and it's more proximal, which is flowing to the distal. It's a bilateral. Please replay the video. It is usually asymmetrical. Okay.
Yes, sir.
Sometimes symmetrical, but one side is more than the other. You see here, please replay the video
Yes.
again. It is very short last video. You should
Yes,
have
sir.
recorded for at least 20 seconds. Very short lasting video.
Okay, sir. Yes.
Yeah. See, along with the proximal shoulder, hand, and even here, the movement is transferred to the head as well. Our head movement is transferred to the hand. What is it, Dr. Ramanan?
No, sir.
The
Patient
hand
or
movement is transferred to the head. Our head movement is transferred to the limbs.
the patient has both titubation and
Okay.
wing beating tremor, sir.
Very
And
good.
subsequently, I have shown the same patient's video for titubation also, sir.
Very nice. Very nice. So this is actually, see, this is very important what you're trying to show to the students and the postgraduates, that we have to ask the patient to attain certain postures, certain limbs have to fit in a perfect and assignment in a adjustments. Like if you ask the patient to outstretch the hands, you will get one kind of tremor. If you ask the patient to put the hands across the chest, you get one kind of tremor. If you put the hands on the thighs at rest, you get one kind of tremor. That's in Parkinson's. That otherwise, what I'm trying to say is, you need to ask the patient to demonstrate certain postures. Okay.
Okay, sir.
That's very important. Very good. Go ahead.
So the same patient has titubation, SS type or anteroposterior type.
This actually we should record from the side. That will say yes or no.
Okay, sir.
Fine. Okay, go ahead.
Okay, sir. This is no type, not linked to our topic, but just to have an easy differentiation, I have simultaneously.
Yeah. Replay the video.
Yes. Classically seen in essential tremor. Yes.
Very good. Very good. Yeah, go ahead.
Yes. This is oxoclonus, multidirectional random chaotic eye movements.
So how do you describe this oxoclonus?
It is a multidirectional random
bilateral
chaotic movements.
Continuous saccades, multidirectional saccades in all directions
Yes,
of the
sir.
gauge. In all directions of gauge, you cannot pinpoint a certain gauge. Okay,
Yes.
it's a bilateral.
Yes, sir.
Okay.
This is low saccades, Vardia sign, seen classically in SCAR 2. Here we ask the patient to see right, and the saccades are very slow.
Is it ocular apraxia or slow saccades? Is it apraxia
Actually,
or slow
in
saccades?
video, no, sir. We have informed the patient you can also turn the head, sir.
Okay,
so that's why he's turning the head, sir.
Okay.
And when we ask the patient to see left, there is no blink, sir. If there is a blink, subsequently head turn and then eyes turn, we will call as oculomotor apraxia, sir.
Okay. So what you're trying to show, you ask the patient to look to right or left here. Replay the video from the first.
Yes, sir. So first we have asked the patient to look to
Look
left,
straight. Okay. Now you ask the patient to look to the left,
left, sir.
Yeah.
Yes, sir.
So he looked left, eyes went to the left, then head moves.
Now we are asking him to turn right, sir.
Eyes came to the right, then head is coming. Okay. So what you're trying to tell the differentiating point from oculomotor apraxia?
Sir, in oculomotor apraxia, patient will not able to turn. First, the head turns with a blink. Subsequently, the eyes
Reverse of
will
what
adjust,
you
sir.
are seeing here. Reverse of what you
Yes,
see,
sir.
right?
Yes, sir.
Eye
Yes, sir.
movements lag behind the head movement. Huh? Head
Yes,
moves
sir.
first, then eyes move. Here eyes are moving.
Yes, sir.
Eyes are moving, then
Yes,
head
sir.
is coming.
But slowly moving, sir.
Yeah, slow,
Yes, sir.
slow. That's good. Very good. Why it is slow here? What is the pathophysiology or mechanism of absoclonus mechanism of slow saccades in cerebral diseases? Any idea?
The mechanism, I don't know, sir. Sorry,
Mechanism.
sir.
Why it is slow? In saccadic components, you know, no, it has a latency, amplitude, velocity. The velocity,
Yes, sir.
what is the role of cerebellum in production of the saccades in pursuits? Saccades pathway, you know. So what is the role of cerebellum? Where it is helpful? Like you said, hypermetry saccades, hypermetry saccade. Velocity of the saccade is predetermined by this cerebellum. Where
Cerebellum
because
and
cerebral
basal ganglia.
degeneration, so velocity becomes slow. That's why
Okay, sir.
saccades are becoming slow. Simple.
Yes.
Why it is
Yes.
absoclonus? What is the mechanism of absoclonus?
Because of impaired check response, patient is not able to
That is called
maintain
rebound
the.
nystagmus. That is called rebound nystagmus. What is the classical eye signs of cerebellum? Most common oculomotor dysfunction which you see in cerebral disease is most common.
Sir, gaze evoked nystagmus.
Yes, very good. Gaze evoked nystagmus is the most common. And what is the characteristic eye sign of cerebral disease? Characteristic. If that is there, means that is cerebral. Characteristic.
Dysmetric saccades.
Rebound nystagmus. Rebound
Okay,
nystagmus.
sir.
Okay.
Okay, sir.
Fine.
Yes.
Okay. And okay, go ahead.
Yes. This is a video of square wave jerks. Patient has horizontal saccadic intrusions with intersaccadic intervals, sir.
Yes.
Sir, actually, this is a case
What
of
you're trying to say
PSP.
here, you're asking the patient to look right or left. What? Can you just explain
No, sir.
slowly?
Sir, I asked the patient to look at my nose, sir.
Okay.
There is spontaneous saccadic horizontal intrusions with an intersaccadic pause, sir.
Replay the video. Okay.
This is our case of PSP, sir. In
Okay.
PSP also we can have square wave
Yes,
jerks,
yes.
but for yes. This is
Okay.
ocular flutter. These are also unidirectional saccadic intrusions without an intersaccadic pause, sir.
Very good.
I will play again, sir. It is
Yeah.
also short video, sir.
Yeah. Who has taken all this video? You yourself recorded?
Sir, these a few videos are of my HOD, sir. These
Very
two
good.
are of mine, sir.
Very nice, very nice. My suggestion to you is, if you are taking video, please take in little zoom in and take for at
Okay.
least 60 seconds.
Okay,
Because
sir.
these videos are very short lasting. Maybe
Yes, sir.
patients are not giving you time, I think, or you might be busy in recording. Fine. Yeah, replay the video, ocular flutter.
Yes, sir.
His eye movements, are they full? Spontaneous
Yes,
eye
sir.
movements,
His
are
eye
they full?
movements are full, sir. Full, sir.
Because I'm not able to see any movement in the eyes.
No, sir. We have asked the patient to fix his
Okay.
gaze at my nose, sir.
With your
And
nose.
these are yes, sir.
This is what you are seeing. Like, replay the video once.
Spontaneous involuntary unidirectional saccadic intrusions with without intersaccadic intervals, sir.
You identified interval in square wave jerks. You identified
Yes,
no
sir.
interval in ocular flutter. Huh?
Yes, sir.
Okay, go ahead. In video for me, it's very difficult to pursue. It's fine. You identified, you understood, fine.
Yes.
Go ahead.
Yes. So this is lateralizing ataxia.
Mm-hmm.
Patient has left-sided ataxia, sir.
Mm-hmm.
Patient's face to left while attempting a tandem gait, sir.
So
And
he's
this
veering
is
to the
a
left side while
non-lateralizing
walking,
ataxia.
tandem gait.
Yes, sir. Yes,
Okay.
sir.
Okay. So you
This
think
is a patient's
she's
face
having
either side,
uh,
right cerebellar issue, sir. In this video, she's face either way, sir, while performing a tandem gait.
okay. Replay the video once.
Yes, sir.
Okay. So you checked in both by asking the patient to close eyes. You observed what was happening to these patients, these two patients on closing the eyes, like standing with feet together and closing the eyes, or standing. How is their, what do you say, base? Is it normal or wide?
Wide base, sir.
Wide base. Okay. What was happening to their gait on closing the eyes?
Sir, actually, I didn't check with eyes closure, sir.
Okay. No, why I'm asking this is sometimes you can have combined. Okay.
Okay, sir.
That's
Yes,
the reason I'm asking. Okay, go ahead.
yes, yes. So this is scanning dysarthria, sir. I'm very sorry if audio is not coming, sir.
Not coming, huh? Okay. Okay, you understood, Allah. What is scanning?
Sir, in scanning dysarthria, patient will give impetus to each consonants of the word, or
Yes.
in other ways, patient will break a word into each syllable and they
Intrasyllabic
will
distance
pronounce
is
it
increased.
separately, sir.
Yeah.
Yes, sir.
Intrasyllabic
And
distance is increased and there are unnecessary
yes, sir.
hesitations and stops. Okay, done.
Yes, sir. This is abnormal heel shin test and finger nose test, sir.
What is staccato, you said? What is staccato?
Sir, at the end, there will be an explosive nature, sir.
Accentuation of syllables when not needed. Omission
Yes,
of pauses when needed. Right, very good.
yes.
And what you are demonstrating here? Abnormal heel knee test and finger nose test. Dr. Ramanan, when we do heel knee
Yes,
test, even before we ask the patient to put the, let the heel of the other leg go along the shin of the tibia, even before that, we have to put the heel of the leg, we have to ask the patient to try to keep over the patella. Okay.
okay,
Even the person with heel knee ataxia will not be able to keep sustainedly over the patella. Then
okay, sir.
one is unable to put, then you ask the patient to let the heel draw along the shin of the tibia. Please show again heel knee test. Replay the video. See, he's starting in the middle, tibial
Yes, sir.
tuberosity. From the tibial tuberosity, he's drawing she's drawing the heel. Instead, what we should ask the child is put the heel on the patella, try to keep.
Okay, sir.
Then there itself, she wobbles. The heel wobbles. Heel becomes unstable. She will not be able to keep, and it goes this way and that way. Then it affirms and confirms that it has initiation itself is a problem. Then when you ask the patient to go down the shin of the tibia, it goes away, out of the way.
Yes,
okay. And you should check in both legs. You are demonstrating only left leg. What about the right leg? It is symmetrical or asymmetrical? Every sign you are demonstrating, as you are showing in the video, maybe you must have been examined. Always check right side, left side, and check for the symmetry. Right side, left side, is it symmetrical or not?
Yes, sir.
Because why is it important?
Sir,
Tell me why it is important.
because the cause for symmetrical
Yeah.
and asymmetrical attacks are different, sir.
Very good, very good. Most of the genetic ataxias are symmetrical, whereas
Yes,
acquired
sir.
disorders are usually asymmetrical. Very good. Play the
Yes,
video.
sir.
Fingernails test is not coming.
It's yes.
No, it's not playing.
So this is of right leg heel knee test.
Okay,
Subsequently,
okay.
left leg is performed.
See, he's putting the leg slantly. You should keep first right leg should be kept straight. Right leg
Okay,
should be
sir.
kept straight, and left leg should
Yes,
be
sir.
straight on the patella. Then slide down the shin of the tibia. Right
Okay,
leg
sir.
is kept, externally rotated. Instead, it should be kept
Oh,
straight. Okay, what are all
okay,
the
sir.
variations of doing fingernails test, and what are all the various tests of limb incoordination in upper limbs? What are all the variations of this so-called fingernails test? We have finger chase test,
Okay,
right?
sir.
Huh?
Yes, sir.
You know that finger chase test? Like I said in your video, first video, we have to move rapidly the examining finger from one direction to another direction. He should be able to reach out to the target, because what we are trying to check here is goal-directed activity. Goal-directed activity is the one which is classically affected in cerebellar diseases.
Yes, sir.
Okay. Upper limb coordination is classical of cerebellar outflow tract. That is what you are trying to say, superior cerebellar peduncle abnormality, or dentato-olivo, dentato-rubro-thalamic cortical pathway dysfunction. That's what. Okay. What are all the
Yes.
other tests to demonstrate limb incoordination in upper limbs? You might be having next videos, I think, like demonstrating rapid alternating movements, rapid pronation, supination in unsupported position, right?
Sir, I don't have those videos, sir.
Okay, fine. Someone has written in the chat box,
Yes.
finger nose finger test, correct? Finger nose test, finger nose finger test, finger chase test, rapid alternating movements, rapid pronation, supination in unsupported positions, or alternately tap with palm and dorsum of the hand over stationary hand and thigh. You can do that way. And demonstrating rebound phenomena. Rebound phenomena, upper limbs, how do you demonstrate, Dr. Ramanan?
Sir,
Have you ever
we
checked
have
rebound
to.
phenomena?
Yes, sir. We have checked
Yeah.
rebound phenomena.
Do you
sir.
have video of that?
Sir, no, sir.
Fine, no issues. If you get a case next time, kindly check for the
Yes, sir.
rebound phenomena that you said already in the theory. That is due to, why is it due to, what is the mechanism?
Impaired check response of the antagonist muscle, sir.
What did you understand that by that term, impaired check response by antagonistic muscles? So for any movement to happen, where is the movement generated from? Movement. You imagine that you want to flex the elbow or biceps. You need to activate the biceps. Okay, you imagine your brain that yes, I have to flex the right biceps. So where is the movement patterns generated?
The supplementary motor area of the contralateral side, sir.
Yeah, motor cortex. Okay, fine.
Yes.
Movement is
Yes.
planned in?
The planning is done in supplementary motor area. The plan
Basal
is
ganglia.
sent to
Basal
the
ganglia.
motor cortex.
Basal ganglia.
Okay.
Planning is done by basal ganglia. Coordination
Okay,
of this cortex, basal ganglia, and the lower motor neuron, skeletal muscles and nerves is done by cerebellum. Coordination. What is the term exactly coordination means? We use the term here everywhere in examination, in history, whenever I ask, we use the term in coordination. What is that coordination actually? Coordination is a hierarchy. What is it? What did you understand by the term coordination?
Sir, it is synchrony in the rate, rhythm, and strength for a particular movement to occur, sir.
Very good. For any movement to happen, you have certain group of muscles called agonists, which initiate the movement. And there are certain group of muscles called antagonists, which inhibit the ongoing movement. And there are certain group of muscles called synergists. Okay, synergist which fixate the muscles. Okay, you know that, no? Agonists, antagonists, synergists, fixators. Synergists are the muscles which facilitate the ongoing movement. Fixators are the one which limit the ongoing movement. These are the four group of muscles: agonists, antagonists, synergists, fixators. Coordination between these four group of muscles is called coordination to facilitate the ongoing movement and to inhibit the excessive movement. Okay, if excess movement happen, that's what we call overshooting.
Yes.
If before reaching the target, if a object stops, that's what we call undershooting.
Undershoot.
Hypometria, hypermetria.
Hypermetria.
So
Yes.
this all coordination is a function of the cerebellum. That's what you are all trying. You are trying to demonstrate in all the things, right?
Yes, sir.
Fine, very good. Go ahead. And impaired check response is like what you said? Inhibition of
Sir, it is due to impaired check response of the antagonist muscle, sir.
antagonist muscle. Very good. What is dysdiadochokinesia?
Sir, it is inability to perform a rapid alternating movement, sir.
Very good.
Like a pronation supination movement, sir.
Okay. What is dysrhythmokinesis? Any idea?
Sir, I don't know, sir.
Read about it. Huh? What are the tests
Yes,
of limb coordination in lower limbs apart from what you have shown? Heel to shin
Sir,
test.
we can ask the patient to tap the floor and dorsiflex and plantiflex the
Very
ankle,
good.
sir.
Very good. Next.
And we can ask the patient to make a circle with the foot, sir.
Very good. Next.
Then
Toe to finger test. Like you said,
okay,
toe
sir.
to finger test.
Yes, sir.
Okay. And then how do you check rebound phenomena in the legs?
Sir, we have to flex the hip and flex the knee at 90 degree. Then we have to ask the patient to extend the knee suddenly against resistance, and suddenly we have to remove the hand,
Release
sir.
that.
Yes, sir.
Okay. So, okay. What about specific reflexes you get here in the cerebellar disease? Pendular knee jerk. Do you have any video of it? Pendular knee jerks.
Sorry, sir, I don't have, sir.
Fine. When do you say pendular knee jerk?
Sir, more than 3 oscillations after tapping the patellar tendon, sir, it is due to hypotonia, sir.
Very good. Very good. Okay. Go ahead. Go ahead with the talk.
Yes. Yes. And why cerebellar symptoms and signs are unilateral? The reason is because of double crossing of corticopontocerebellar tract and dentatorubro-thalamic cortical tract.
Very good.
Coming to general exam, 2-foot examination, in head we can have gray hairs seen in ataxia telangiectasia, alopecia seen in ectodermal dysplasia with ataxia, pallor seen in vitamin B12 deficiency, telangiectasias can be seen in ataxia telangiectasia, KF ring seen in Wilson's disease, cataracts can be found in cerebrotendinous xanthomatosis, mitochondrial disease, and Wilson's disease. Cherry red spot can be seen in sialodosis, Tay-Sachs disease. Retinitis pigmentosa can be seen in NARP and Refsum disease. Optic neuropathy can be seen in Friedreich's ataxia, and thyroid enlargement can be seen in hypothyroidism. Cardiomyopathy or cardiac conduction defects can be seen in Wilson's disease and mitochondrial.
Friedreich's
This
ataxia
is
also you get
the
cardiac, right?
sir.
Friedreich's also you get cardiomyopathy, right?
Yes, sir. Yes, sir. We will get, sir.
Okay. Go ahead.
Yes. This is an image showing telangiectasia in the eyes, sir.
Bulbar conjunctiva you are showing.
Yes, sir. Bulbar conjunctiva.
Where else you see for telangiectasia?
Ear lobules we can find, sir.
Very good.
And nail beds, sir.
Yes. What is meant by telangiectasia?
Sir, it is the capillary is very prominent and it is tortuous, sir.
Okay. Okay. What is the second finger? This one. Someone has written chat box. It is seen in uvula. Uvula also you can see. Telangiectasia. Okay, done. Next. What you are trying to demonstrate in the second figure?
Yes, sir, it is a Keisher-Fleischer ring, sir, seen classically in Wilson's disease, sir.
What is KF ring? Made of
sir,
what?
it is due to deposition of copper in Decimet's membrane of the cornea. The Decimet membrane is an avascular layer, sir. So it has less metabolitic activity, and it is also avascular, sir. So the metabolites are less cleared off, sir. and it has rich collagen supports collagen matrix, sir. So all these factors favor the copper deposition in that layer, sir,
What
decimus
does it
membrane.
signify?
That
That
is why
patient
we are
has
seeing
K-ring means what?
the
What does
patient
it
has
signify?
sir, copper metabolism is impaired, sir, because of
No, if you are
uh,
saying
yes,
K-ring means neurology is already involved or not yet involved.
sir, it is involved, sir.
It says it's indirectly that is a
Yes,
neurological
sir.
dysfunction. Yeah,
Yes,
someone
sir.
has written neurobusiness. Correct. Very good. Go
Yes, sir.
ahead.
And the order of appearance of KF ring will be
Yeah.
initially in the superior quadrant,
Yes.
followed by inferior quadrant, followed by nasal and temporal quadrant. After treatment, the disappearance is in the reverse order, sir.
Yes. Okay. Go ahead.
Yes. Yes. This is tendon xanthoma seen in cerebrotendinoxanthomatosis.
Okay.
Next,
So is your
coming to,
patient or a textbook picture? Xanthomas.
so this is textbook picture, sir.
Very good. Very good.
Yes. Next, hepatosplenomegaly can be seen in Wilson's disease, Tay-Sachs disease, Niemann-Pick type C, Whipple's disease. Malabsorption can be seen in celiac disease. Short stature seen in ataxia telangiectasia and mitochondrial. Hypocoliosis seen in Friedreich's ataxia, ataxia with vitamin E deficiency and A beta lipoproteinemia. Macular hyperpigmentation is seen in vitamin B12 deficiency. Polydactyly is seen in Joubert syndrome. Tendon xanthomas are seen in cerebrotendinous xanthomatosis. Pes cavus and hamartos can be seen in Friedreich's ataxia. Dry skin and ichthyosis can be seen in hypothyroidism, Refsum's disease. Vitiligo is seen in ataxia telangiectasia. Dry skin, sunburns, propensity to develop skin cancers are seen in xeroderma pigmentosum, and hirsutism can be seen in drugs like phenytoin.
Okay.
Then coming to combination of symptoms like acute or subacute cases of ataxia with myoclonus, we remember the mnemonic for vitamin for etiology. Among infectious causes, CJD and SSPE can have both ataxia and myoclonus. Among autoimmune causes, we can have autoimmune encephalitis having both ataxia and myoclonus. In inherited cases, we have ataxia telangiectasia, SCARS, Ramsay-Hunt syndrome, and Polg ataxia. And in neoplastic, a paraneoplastic syndrome, opsoclonus myoclonus syndrome can have ataxia and myoclonus, sir. So this is Ramsay-Hunt syndrome types, type 1, type 2, type 3. Type 1 is associated with cerebellar issue. It is a neurodegenerative condition where patient will have ataxia, myoclonus, tremors, and seizures.
Okay.
Then another combination, atrophy and retinopathy. It is seen in Friedreich's ataxia, SCAR7, mitochondrial disease, Refsum disease, vitamin E disease, and multiple sclerosis. Coming to ataxia with peripheral neuropathy combination, can be seen in Friedreich's ataxia, ataxia with vitamin E deficiency, A beta lipoproteinemia, ataxia telangiectasia, oculomotor apraxia, Refsum's disease, cerebrotendinous xanthomatosis, many types of SCA, vitamin B12 deficiency, tabes dorsalis, and alcoholism.
In this, you can say where do you get. Go back.
Yes, yes.
In this, instead of saying broadly peripheral neuropathy, you could have said where do you get pure sensory neuropathy? Pure sensory
sir.
neuropathy, mixed neuropathy, like that. Pure sensory, where do you get it?
Friedreich's ataxia,
Yes.
Friedreich's ataxia, ataxia with vitamin E deficiency, A beta lipoproteinemia, all these three things will have sensory neuronopathy, sir. So they will have pure sensory symptoms, sir.
Tabes dorsalis?
Sir, first three I told, sir. Subsequently,
Yeah.
I thought I will come,
Yeah. Okay.
Then ataxia telangiectasia, apraxia with oculomotor apraxia, Refsum's disease, cerebrotendinous xanthomatosis, CA1, 2, 3, 4 will have sensory motor neuropathy, sir.
Okay.
Vitamin B12 deficiency predominantly will have large fiber neuropathy, sir. And tabes dorsalis will also have a posterior column
large
involvement,
fiber
sir.
means sensory only, no? Large fiber means
Yes, sir,
what? It
sensory
has
only,
different
sir.
function or what? Large fiber means sensory only, na?
Okay, sir. Yes, sir. Yes, sir.
Okay.
Yes, sir.
Yeah.
And tabes dorsalis is also sensory, and alcoholism again sensory, predominantly small fiber, sir.
This is what see this very important table which you have written. Clinically, for postgraduates in the final examination in MD and DM, they ask usually absent anculature with extensor plantar. Where do you get? That's what is. These are the causes which you have written. So absent anculature with extensor plantar. Where do you get of these causes?
Sir, we will get in Friedreich's ataxia, copper deficiency, SACD, and vitamin E deficiency, HIV, and
Nitrous oxide? Nitrous oxide
nitrous
exposure?
oxide poisoning, sir. Yes, sir.
What about TBs?
Yes, sir.
TBs
TBs also we will.
Yeah.
Yes.
Okay. How do you differentiate Frederick as a neuropathy versus vitamin E deficiency?
Sir, both are morphologically will be very similar, but in ataxia with vitamin E deficiency, the head tremors are more than that of Friedreich's ataxia, sir.
You don't get dysarthria and Babinski's in vitamin E deficiency,
Okay, sir.
which you get in Freddy's. No dysarthria and no Babinski's in vitamin E deficiency, which are classically you
Okay,
get in
sir.
Friedreich's ataxia. Okay.
Okay, sir.
Okay, go
And
ahead.
okay, sir. Cerebellar cognitive affective syndrome, which is also known as Shamaman syndrome. The key features of cerebellar affective syndrome are cognitive deficits like language issues, executive dysfunction, and visuospatial impairments, and emotional or affective changes like blunted affect, depression, irritability, or anxiety, and emotional dysregulation, and behavioral changes like apathy or lack of motivation, personality changes, or reduced social interaction. It is predominantly localizes to posterior part of the vermis.
Yes.
Next, the classification based on symmetricity and onset. So this picture is taken from Harrison, sir.
Harrison, yeah.
Yes, sir. The first three is symmetric side, and this half is asymmetric curve. And based on onset, acute, subacute, and chronic, the causes for acute symmetric ataxia can be alcohol, lithium, phenytoin, barbiturates, acute viral cerebellitis, and post-infection syndrome. In subacute symmetric ataxia, it can be due to mercury intoxication, solvents, gasoline, glue, cytotoxic agents, chemotherapeutic agents, and alcohol causing nutritional deficiency like vitamin B1 and vitamin B12 and Lyme's disease. Among chronic symmetrical ataxias, predominantly these are hereditary, sir, and paraneoplastic syndrome, anti-gliadin antibody syndrome, hypothyroidism, inherited disease, tabes dorsalis, phenytoin toxicity, and amiodarone, sir. Focal and
Paraneoplastic cerebellar
ipsilateral
syndrome are associated with which antibodies? Which antibodies?
the pure yo, re, ma, ta, hu, sir.
Anti-Hu, yeah.
Yes,
Okay.
sir. And ipsilateral cerebellar signs of acute nature, usually vascular, that can be infarct or hemorrhage or hematoma.
Okay.
Because cerebellar glioma or metastatic
You read
tumors.
abscess very important. Following otitis media in children,
Yes, sir. Yes, sir.
complication of otitis media cerebellar abscess very, very common presentation in children,
Okay,
which
sir.
is important. Focal ipsilateral acute dysfunction.
Yes, sir.
Okay, go ahead.
Yes, sir. Then among subacute causes, neoplastic causes like cerebellar glioma, metastatic tumor, and demyelinating causes like multiple sclerosis and AIDS-related multifocal leukoencephalopathy can cause asymmetrical ataxias, subacute nature, sir. Then chronic asymmetrical ataxias predominantly related to gliosis because of an older insult of ischemic or hemorrhagic origin, then a demyelinating plaque, then a congenital lesion like a Chiari malformation, Dandy-Walker syndrome can cause asymmetric chronic ataxia, sir.
What is Dandy-Walker malformation?
Sir, it is absent vermis with a large posterior fossa with small cerebellar hemispheres which is pushed superiorly, sir.
Cystic expansion of the floor of the fourth ventricle due to atresia foramen of Megendi and Luschka.
Okay, sir.
Cystic expansion of the floor of the fourth ventricle due to atrophy of foramen of Megendi and foramen of Luschka. Okay, go ahead.
Sir. Yes. Sir, foramen of Megendi and Luschka will get enlarged due
Atresia,
to vermis
atresia.
atrophy or
Vermin
atresia.
atrophy will be
sir.
there.
Yes.
The pathophysiology is atresia. It's not formed at all.
Okay.
Okay.
Sir. Yes. Then coming to etiology, causes of ataxia, vascular can be strokes, superficial siderosis, and hypoxic ischemic encephalopathy. Then among infectious, viral, HIV, HSV1, 2, varicella zoster, Epstein-Barr virus, cytomegalovirus, Coxsackie virus, and enterovirus and influenza virus. Like bacterial, tuberculosis, syphilis, Lyme's listeria, Whipple's, mycoplasma, cerebellar abscesses, and CJD. In Whipple's, we have a characteristic clinical features of ocular myurhythmia, sir, and oculopalatal fasciculation, sir. Listeria is common to cause rhombencephalitis, sir,
Yeah.
which is common in elderly immunocompromised individuals.
Ramadan, you have not written the most
Then,
common things
yes,
which
sir.
we see in our practice here in India, especially in South India. Malarial cerebritis. Malaria.
Okay, sir.
Malaria is common. Dengue is common.
Okay, sir.
You haven't seen any virus cerebritis due to dengue?
Sir,
Dengue is
cerebritis I
there.
haven't seen,
Malaria.
sir.
Malaria.
Okay.
Malaria is very, very common.
Okay, sir. Okay, sir.
Okay. Might be textbooks not have added because textbooks have been written by Westerners, not by Indians. But in Indian varieties, we should never forget malaria and dengue.
Okay, sir. Yes, sir.
Right. Go ahead.
Then among toxic causes, ethanol, anti-seizure medications like phenytoin, valproate, carbamazepine, oxcarbazepine, lamotrigine, zonisamide, amiodarone, metronidazole, chemotherapeutic drugs like 5-fluorouracil, cytarabine, capicetabine, and methotrexate.
Which
Heavy
cell
metal
of the
poisoning like
Parkinson, which cell of the cerebellum is sensitive to these drugs? Which cell?
the
You said
dentate
so much.
nucleus, sir.
I read it is Purkinje
Purkinje
cell
cell. Yes, sir.
due to
Purkinje cell, sir.
phenytoin. Purkinje cell.
Yes, sir.
Okay, go
The
ahead.
Purkinje cell is for anti-seizure medication, sir, and the metronidazole is common to affect dentate nucleus. Sir.
Yes.
Yes.
Go ahead.
Yes. Among autoimmune causes, multiple sclerosis, anti-GAD antibody, gluten-sensitive ataxia, which includes anti-gliadin antibodies and anti-TG6 antibody. Post-infectious cerebritis can be seen in varicella zoster, Epstein-Barr virus, mumps, influenza, HSV, CMV, Coxsackie, enterovirus, and mycoplasma. Bickerstaff encephalitis is due to anti-GQ1 antibody, triad, anti-TPO related, and sarcoidosis and clippers.
Okay.
Among metabolic, it can be hypothyroidism, vitamin B1, vitamin B12 deficiency, vitamin E deficiency. The vitamin E deficiency can be of acquired or hereditary in nature, sir. Inherited, and again detailing it in a later slide, sir.
In
Neoplastic,
metabolic, you
posterior
have
course.
in metabolic you have other diseases, right? Heart nerves, urea cycle disorders, like in
Yes, sir.
children, pyruvate carboxylase deficiency, branches in amino acid ureas.
Yes, sir.
All these can cause
Yes,
cerebral
sir.
ataxias. And what is Otto
Yes,
Brewery
sir. I
syndrome?
have. Sorry, sir.
Otto Brewery syndrome.
Sir, I do not know, sir.
Due to this, they say it is due to systemic candidiasis. In systemic candidiasis, you have alcohol production, which is likely to produce ataxia. Otto Brewery, Brewery. Okay,
Yes, sir.
go ahead.
Yes, sir. Sir, that branched chain amino acids I have clubbed into intermittent ataxia, sir.
Oh,
So
okay.
I am explaining it in later.
Very nice,
Yes, sir.
very nice. Go ahead.
Yes, sir. Among neoplastic causes, it is posterior fossa mass like medulloblastoma, astrocytoma, ependymoma, hemangioblastoma, and peanuts, metastasis, and paraneoplastic like Yo, Re, Ma, Tahu, VGCC, CV2, CRMP5, TR, and DNR, mGlu-R1 cell. Most commonly, these are associated with the small cell lung cancer, ovarian cancer, breast cancer, and Hodgkin's. Among these things, Yo, Re, Ma, Ta are known to cause pure cerebellar syndrome, sir.
Okay.
Next, among structural causes, CV junction anomalies, Dandy-Walker syndrome, and Joubert syndrome, cerebellar aplasia by hypoplasia.
Okay.
Coming to inherited causes, for inherited causes, based on the age, we will classify as early onset and late onset. Early onset usually associated with autosomal recessive, and late onset usually associated with autosomal dominant, which is less than 25 and more than 25. Among early, but there are few scars which can happen in early onset. Like in childhood onset, we can have scar 2, 7, 13, 25, 27 DRPLA. And young adult, we can have scar 1, 2, 3, and 21. These are probably due to the anticipatory effect of the repeat mutation expansion, sir. Then late onset ARCAs, again, ARCA, as classically we tell it is less than 25. Still, we can have the onset beyond 25, as we see in Canvas syndrome and LOFA, sir, which is late onset Friedreich's ataxia, sir.
What is
Then
canvas
coming
means?
to
What is canvas means?
sir, cerebellar ataxia with neuropathy with vestibular areflexia syndrome, sir.
Okay.
Which is due to RFC1 gene mutation and which is due where there is a pentanucleotide repeat expansion, sir. Yes, sir. Sir, coming to genetics, we have autosomal recessive ataxia with known gene mutation like ataxia telangiectasia, ATM gene mutation, ataxia telangiectasia like disease, MRE11 gene mutation, AOA1 APTX gene mutation, AOA2 SETX gene mutation, AVED alpha tocopherol gene transfer mutation, A beta lipoproteinemia MTTP gene mutation, RSAX SAX gene mutation, cerebrotendinous xanthomatosis CYP27A1 gene mutation, CANVAS RFC1 gene mutation, Friedreich's ataxia FXN gene mutation, and Niemann-Pick type C NPC1 NPC2 gene mutation, and spinocerebellar ataxia with others like infantile onset SCA, Marinesco-Jogren syndrome, Repsum disease, SCAN1 and SPG7, sir.
Oh,
Now, autosomal recessive ataxia with unknown gene mutations are basically termed as early onset cerebellar ataxia, sir.
okay.
Next, X-linked ataxia, we have FXTAS, where there is FMR1 gene mutation. Again,
What is
it is
that
a
full form of
trinucleated
FX test means what?
fragile X tremor ataxia
Fragile.
syndrome, sir.
Okay.
Yes,
Right.
sir. And it is of elderly onset, sir. And FMR gene 1 mutation. Here, again, there is a trinucleated repeat expansion of GAA gene, sir.
What is the
Repeat, sir.
phenotype? How do they
And
look like? Fragile X. How do they look like? Large ears, large testes.
okay, sir.
Have large ears and large testes, right?
Yes, sir. Yes, sir.
Yeah. Okay. Go ahead.
Yes, sir.
And they have
So then
autism.
autosomal. Okay, sir.
Autism as well, right?
Yes, sir. Autosomal dominant cerebellar ataxia is CA and episodic ataxia, sir. Among mitochondrial, we have MERF, Kearns-Sayre syndrome, Golgi ataxia, and CoQ enzyme deficiency. Now coming to ARCA classification, we divide basically on the mechanism by which the disease occurs, sir. So mitochondrial dysfunction, ARCA's disease include Friedreich's ataxia, infantile onset cerebellar ataxia, CoQ enzyme deficiency, Golgi ataxia, SPG7. And metabolic AVED, A beta lipoproteinemia, CTX, Niemann-Pick type C, late onset Tay Sachs disease, Repsum disease, and autosomal recessive cerebellar ataxia with cytoskeleton protein. Then based on DNA repair defect, it can be AT, ATLD, AOA, spinocerebellar ataxia with ataxic neuropathy, and mitochondrial recessive ataxic syndrome. Then based on protein scaffolding defect, it can be RSAX and Marinesco-Jogren syndrome. Coming to late onset degenerative ataxia, we have three classes: old to new, Greenfield classification, Anita Harding classification, and latest is genetic classification. So Greenfield classification was made on 1954. So they have divided into predominantly spinal, predominantly cerebellar, and combined spinocerebellar. Predominantly spinal, we have Friedreich's ataxia, A beta lipoproteinemia, and hereditary spastic paraplegia, where predominantly the degeneration is happening in the dorsal column pathway and spinocerebellar pathways. And predominantly cerebellar, it is ataxia telangiectasia, late onset cervical cerebellar atrophy, and Marinesco-Jogren Garland disease. Combined spinocerebellar, hereditary spastic ataxia, Ramsay-Hunt syndrome, hereditary periodic ataxia, and olivopontocerebellar atrophies. Coming to ATCA classification, this is based on Anita Harding's classification in 1982. She has divided into ATCA 1, ATCA 2, ATCA 3, and ATCA 4. Cerebellar ataxia with variable extracerebellar sign is ATCA 1. Cerebellar ataxia with pigmentary macular degeneration is ATCA 2. Only one SCA7 is in this group. And cerebellar ataxia, pure cerebellar ataxias are SCA3, which is example SCA6, 11, 14, 15, 16. And SCA4 are cerebellar ataxia with seizures, SCA10 and 17. Sir, in some references, ATCA4, I found cerebellar ataxia with deafness also, sir. Which one is correct, sir?
Even I felt this seizures one. We'll refer
Okay,
again.
Yes,
Share the reference, what you found with the deafness and seizures, okay?
Yes, sir.
Reference, okay?
Okay, sir.
Right.
This is a genetic classification of SCA. So SCA, we have repeat expansions and mutations happening in single point mutations that can be insertion or deletion. Then there is linkages mapped, but the exact nature of mutation is not identified. So again, in another way, so this is 5' to 3' chromosomal architecture. We have 5' end and 3' end, and exons and introns. In 5' end, if the CAG is having multiple repeats, it is usually seen in SCAR12, which is common in India, tremor predominant type, also known as Agarwal's type. In exon, if CAG repeats are seen, it can be in SCAR1, SCAR2, SCAR3, SCAR6, SCAR7, SCAR17. And in 3' end, if we have CTG repeats, it is seen in SCAR8. In introns, if we have GAA repeat, it is SCAR27B. It is one of the treatable SCAR where 4-aminopyridine has been tried and it has shown improvement.
Yes.
In intron, we have pentanucleotide repeats in SCAR10 and SCAR37, and hexanucleotide repeats seen in SCAR36. Yes, sir.
Oh.
The non-repeat expanse mutation where the exact genetic mutation has been identified, like the SCAR5, SCAR13, SCAR14, SCAR16 or 15, 27, 4, 11, and 28. This SCAR27, again we divided into SCAR27A and SCAR27B. SCAR27A is also a treatable SCAR where they have tried acetazolamide for treatment, and SCAR27B, they have tried 4-aminopyridine for treatment, sir.
Okay.
So based on non-repeat expansion, the non-repeat expansion, we will have variable age at onset, that is no anticipation. And in repeat expansion, we will have anticipatory phenomenon where the onset in subsequent generations can be earlier and clinical manifestations can be severe. Then slowly progressive ataxia, and here rapid progression. Childhood onset is not severe, here it is juvenile. Predominant Purkinje cell is lost, and here there is diffuse neuronal cell loss. The major downstream mechanisms are impaired ion channels, mitochondrial dysfunction, and impaired mitophagy, transcriptional dysregulation, and other possible mechanisms like DNA damage and impaired DNA repair pathway as seen in SCAR. Sir, I'm not elaborating it, sir.
Okay.
Clinical clues for suspecting SCAR. In SCAR1, we will have hypermetric saccades and brisk reflexes because of bipyramidal tract involvement. In SCAR2, we will have slow saccades and areflexia because of peripheral neuropathy association. In SCAR3, we will have bulging eyes, fasciculations, and Parkinsonism. Here, they can have pyramidal involvement and ALS type involvement, even peripheral neuropathy and Parkinsonism. So SCAR3, which is called Mercado disease, which is most common among in the world, sir. SCAR 6 and 50 will have downbeating nystagmus. Also, episodic ataxias can have downbeating nystagmus. SCAR 7 is the only group where visual loss can be seen due to retinal degeneration, maculopathy, sir. SCAR 10 can have seizures. SCAR 12 is action tremor, which is also known as Agarwal group of SCAR, which is most common in Indian scenarios. SCAR 13 and 27 can have developmental disability. SCAR 14 can have tremor, myoclonus, and facial myokainia. SCAR 17 can have Huntington-like diseases. SCAR 34 can have tongue atrophy and fasciculation. SCAR 18 can have sensory neuropathy. Deafness, sir. SCAR 40 and SCAR 44, SCAR ataxia. SCAR 12, 15, 16, 20, and 27 can have tremor. SCAR 36 can have MND. And last is pure cerebellar ataxia, which is common in SCAR 6, 11, 15, 16, 20, 26, 29, and the number goes on, sir. This is another representation of the same things which I have told, sir. Reasons for, sir, whenever coming to genetic inherited causes, still we can have negative family history. The reasons being adopted child, non-paternity, small family size, early death due to other causes, sporadic mutations, anticipations. In X-linked, only males are affected. In mitochondrial disorders, maternal mode of inheritance may be apparent, but penetrance is variable, sir. And non-cerebral causes of
one more important point. You added many of the points, very nice. Other important what you missed here in the, you have a genetic disease but no family history is like autosomal recessive pattern of inheritance, where you have skipping of the generations. Autosomal recessive, incomplete penetrance, de novo mutations. These are 3 things to be added here in this table. Okay. Right. Go ahead.
Then non-cerebellar causes of acute ataxia, like acute ataxic variant of GBS, Miller-Fisher syndrome, acute vestibulitis by labyrinthitis. These should be considered in acute symmetric ataxias as differential diagnosis, sir, because the approach and treatment entirely differs. Then reversible causes of ataxias like post-infectious cerebralitis and drug-induced. Coming to episodic ataxias can be primary episodic ataxia, secondary episodic ataxia, and episodic ataxia minitus. So the episodic ataxia 1 and episodic ataxia 2 has been well elaborated in many families, and 3 to 10, actually 3 to 8 are been published, and 9 to 10 are yet to publish. All these will have resemblances to 1 and 2, sir, more of resemblances. And second, vascular, TIA, ischemic and hemorrhagic strokes, APLA, Kawasaki disease, neurobeshettes. Among inflammatory, we can have MS, post-infectious cerebralitis, Bickerstaff brainstem encephalitis, Miller-Fisher syndrome, toxicity like anti-seizure medication, lead and alcohol. Next, autoimmune conditions like Casper2, NMDAR and ANA1. Metabolic disorders like organic aciduria, idiocyclic disorders and aminoacidopathies. Among endocrine, hypothyroidism, neoplastic posterior fossa tumor or occult neuroblastoma. Next, episodic pseudoataxia. In episodic ataxia mimickers like BPPV, migraine with brainstem era, vestibular migraine, vestibular epilepsy, paroxysmal kinesogenic dyskinesias, and functional neurogenic disorders. So, a small brief about EA1 and EA2. Gene involved is KCNA1 gene and CACNA1 gene. The protein is potassium channel and the calcium channel. Age of onset is usually childhood in EA1, and it can be childhood or adolescent onset in EA2. Attack duration is usually seconds to minutes, and here it is hours to days. Frequency, it is multiple times daily, and it can occur weekly or monthly. Myokainia, during the interictal period, myokainia can be seen in EA1 and not seen in EA2. Nystagmus is not seen in EA1 and seen in EA2, even in the interictal period. And other features are like diplopia, dysarthria, nausea, headache may accompany attacks. Neuromyotonia of variable severity is common. Other neuromuscular features like cataplexy, dystonia, distal weakness, and malignant hyperthermia, where sweating, hot flashes, palpitations, like autonomic features can be seen. Here are the other brainstem symptoms like vertigo, diplopia, and tinnitus. And migraine, abdominal pain, seizures, dystonia, and cognitive impairment can be seen. Migraine is reported in up to 50% of cases, and maybe hemiplegic migraine because of this channel involved. Sir. Among migraine of type 2. Next, episodic weakness, other movement abnormalities have been reported, including slowed abduction during smooth pursuit, slow circuit velocities, and excess-induced downbeat nystagmus.
What you need to remember is the gene of this episodic ataxia type 2 is shared by, as you said, familial hemiplegic migraine and SCAR6.
Yes, sir. Yes, sir.
SCAR6 and a familial hemiplegic migraine and type 2 episodic ataxia, they share the same gene. Calcium channel gene on chromosome 19. Okay, go ahead.
And MRI will be normal in EA1 and may show cerebellar atrophy in EA2. And there is response to acetazolamide in sometimes with EA1, but EA2 will respond very good with acetazolamide, sir. So other treatments like anti-seizure medications like sodium channel blockers, carbamazepine, phenytoin, lamotrigine is more useful in EA1. However, acetazolamide and benzodiazepines can be helpful. But in EA2, acetazolamide can reduce or completely abolish attacks. Even we can go with 4-aminopyridine, which is a potassium channel opener. Also, dalfampridine, which is a second generation drug. Topiramate and 4-aminopyridine combination is also effective. Levetiracetam has also been reported to be beneficial in EA2, sir.
Okay.
This is a broad overview of EA classification. I'm not detailing it each point, sir.
Okay, okay.
So these are the other intermittent ataxias like organic acidurias, aminoacidopathies, and idiocyclic disorders. In organic acidurias, we have maple syrup urine disease, 3-methyl-glutamic aciduria, glutaric aciduria type 1, methylmalonic acidemia, propionic acidemia, isovaleric acidemia, and L2 hydroxyglutaric aciduria. In aminoacidopathies, we have maple syrup urine disease, Hartnup disease, phenylketonuria, tyrosinemia 1, homocystinuria, and non-ketotic glycemia. Among idiocyclic disorder, ornithine transcarbamylase deficiency, carbamyl phosphate synthetase 1 deficiency, arginosuccinate synthetase deficiency, arginosuccinate lyase deficiency, and arginase deficiency. They all will have vomiting as common feature and encephalopathy as common features. The triggers like illness, fasting, high protein intake is seen in organic aciduria, and same illness, fasting, stress is seen in amino acidopathies, and illness or stress is seen in urea cycle disorders.
Okay.
Coming investigations, MRI, the ideal section to see the cerebellar atrophy is mid-sagittal T1 weighted image, where we can find the cerebellum floating in the as if it is floating in the view cell. Then axial section will also show widened fourth ventricle. In axial section, by counting the number of foliae also, we can tell the atrophy, sir. More than 6 is present, we can tell it is cerebellar atrophy, sir.
Okay.
And vermal atrophy is specifically seen in alcohol use disorders because it predominantly affects the anterior vermis, sir. Posterior lobe atrophy is seen in Schamaman syndrome. We usually won't see any cerebellar atrophy in Friedreich's ataxia, Paul G ataxia, and ataxia with vitamin E deficiency. In Friedreich's ataxia and ataxia with vitamin E deficiency, instead of cerebellar atrophy, we will see cervical cord atrophy, sir.
Very good.
Then hot cross bun sign is seen in MSAC because of pontine fiber atrophy. Hummingbird sign, tadpole sign, so not related, but I just put it up, sir. PSP because of tadpole sign is seen in Alexander disease because of atrophy of medulla and cervical cord with preserved spons. MCP and corpus callosum sign is seen in FX stars, sir. Mammillary body, periaqueductal gray matter, paraventricular thalamus.
What is it? Go back. Previous slide. What is this? T2 HI means what?
Hyperintensity, sir.
T2 hyperintensity. Okay. Fragile X. Okay.
And mammillary body, periaqueductal gray matter, paraventricular thalamus, T2 hyperintensity is seen in Wernicke's encephalopathy. In GRE sequence, we can see hyperintensity blooming in cerebellum and brainstem surface, seen in superficial siderosis due to iron deposition. In diffusion weighted sequence, there is cortical ribbon sign seen in CJD, and T2 hypointense strips in pons, which is seen in RSOX. Small punctate gadolinium enhancement is seen in pons in Clippers. Then coming to images, this is mid-sagittal section showing cerebellar atrophy, and we can see the prominent ventricle around it, sir, and the CSF happening. And this is section showing cerebellar atrophy, sir. And this is predominant vermis atrophy, which is a midline structure seen in bit higher cut. This is a cerebellar infarct involving the pica territory, where we could see a flare hyperintensity. And this is RSOX, where we can see T2 hypointense strips. So these are the hypointense strips, sir.
Yes.
So this is one of our patients we recently found. Metaboplasticity will have dentate hyperintensity. And FX stars, this is plenial sign, which is also referred to as boomerang sign. Next, FX stars, MCP sign is MCP hyperintensity, sir.
Yeah.
Then in MSAC, we have hot cross bun sign. This is the hot cross bun sign. In Clippers, we have perivascular contrast enhancement, sir. Then NCS in SCA 1, 2, 3, 6, we can have mixed axonal and demyelinating sensory motor neuropathy. In SCA 1, we can have NCV slowing. In SCA 2 and 3, we have sensory motor neuronopathies. In CANVAS, we will have sensory neuropathy, sir. Then serum biomarkers, albumin can be decreased in oculomotor apraxia, apraxia with oculomotor apraxia 1 and 2. Alpha fetoprotein can be increased in apraxia with ataxia with oculomotor apraxia and ARCA3 and AT cell. Ceruloplasmin is decreased and copper is increased in Wilson's. Cholestanol is increased in CTX. Cholesterol is decreased in A-beta lipoproteinemia and increased in AOA1 and 2. Creatinine kinase is increased in AOA2 and ARCA2. Ferritin is increased in aceruloplasminemia. Immunoglobulins are decreased in ataxia telangiectasia. Lactate is increased in ARCA2, DARS2 and Pol G mutation. Vitamin E is decreased in acquired vitamin E deficiencies and A-beta lipoproteinemia. And in A-beta lipoproteinemia, in peripheral smear, we will also see spiked RBCs, sir.
Called acanthocytes.
Sir,
Are they called acanthocytes?
acanthocytes, sir. Yes, sir.
Yeah. Say acanthocytes.
Guidelines for genetic testing. So whenever we suspect an inherited ataxia, adult onset, first we have to exclude acquired cause. Then if we are suspecting genetic cause, we have to see whether family history with known gene or highly suggestive biomarker is present. If yes, we have to go for single gene testing. If this single gene testing is negative, or if we don't have a family history or a highly suggestive biomarker, then we have to go for inheritance pattern based testing, sir. So in sporadic case, we have to first test for repeat expansion testings like 1, 2, 3, 6, 7, 12, 17, DRPLA, FRDF, FX star. If available, FGF14 and RFC1, sir. If this is negative, we have to go for NGS and NGS, which is whole exome sequencing, for whole genome sequencing, sir. Family history, if it is autosomal dominant, again, as mentioned here, we have to go for repeat expansion. If it is negative, we have to go for NGS, sir. In autosomal recessive, we have to go for Friedreich's ataxia and RFC1 gene mutation if it is negative, and we have to go for NGS. Then X-linked mutation, FX class is a repeat expansion testing. If it is negative, NGS. In mitochondrial, we have to specifically ask for mitochondrial whole exome sequencing, sir, because the routine whole exome sequencing will not include the mitochondrial genome panel, sir. So such a flow chart considering the financial issues, it is directly better to go for whole exome sequencing because it can identify a gross genetic abnormalities, wide range of genetic abnormalities.
What is the cost of whole exome sequencing at your center?
Sir, we are doing with Anderson Lab at 10,500, sir, after discount.
Okay. In how many days will the report come?
Sorry, sir?
1 month?
Sir, I'm not audible, sir.
No. How many days it will take for the report to come? How many days?
1 month it is taking, sir.
1 month. Yeah. Okay, go ahead.
Rating scales, we have different rating scales. SARA rating scale, which includes gait, stance, sitting, speech. In ICAR scale, gait, stance, sitting, speech also includes eye movements and limb ataxia. In BARS scale, gait, speech, and appendicular ataxia. In MFAR scales, bulbar function, appendicular ataxia, and stability, sir. Treatment options for treat ataxia with vitamin E deficiency, we can give high dose of vitamin E. Autoimmune based ataxia, we can treat with steroids, IVIG, rituximab, etc., other immunosuppressants. And episodic ataxia, as described before, acetazolamide, 4-aminopyridines, and sodium channel blockers can be tried according to the type. In Niemann-Pick type C, we can give miglustat. Pharmacological management for symptoms. For ataxia, riluzole improves ataxia in SCA and Friedreich's ataxia. 4-aminopyridine improves ataxia in EA2 and also in SCA27B. Valproic acid and TRH injection improves SCA3. Branched chain amino acids and IV trehalose for amino acidopathies. Amantadine shows improvement in gait and appendicular ataxia in Friedreich's ataxia. For eye movements, 4-aminopyridine is shown to improve downbeat nystagmus. Baclofen is effective for periodic alternating nystagmus, down and upbeating nystagmus. Memantine plus gabapentin shows improvement in median eye speed and visual acuity. Tremor, propranolol, primidone, topiramate, benzodiazepines, botulinum toxin can improve. Symptomatic orthostatus can improve with midodrine and fludrocortisone, mainly used in MSA. Neurogenic bladder will improve mirabegron and sulfasalazine. And in cognition, memantine can help. Depression, anxiety, and irritability, fluoxetine and citalopram can help, which are SSRI and SNRIs. Pharmacological therapies based on current research, citalopram has been tried in SCA3, baclofen and chlorzoxazone has been tried for ataxias, omviloxazone has been tried for Friedreich's ataxia, and troriluzole has been also tried for SCA. Sir, with this, I am.
Yeah, very nice. What are the references, man? From where you have written all these things?
Sir, based from an article, sir, but I forgot to quote the references, sir.
Yeah. Which article? Which journal? Who has written the article? What is the name of the scientist or the neurologist or researcher?
Sir, I exactly don't remember, sir.
No, no, I just want to know because you have written so much exhaust to material. Is it from one source or different sources?
Sir, the clinical anatomy is from De Jong, sir.
Mhm.
Physiology part, I took it from physiology book, sir.
Which book?
Sir, Sharada Subramaniam, and one more book I saw, sir. Sir, I could not collect suddenly,
You
sir.
should remember the books, man. You read so much, you forgot the names of the books, huh? Okay. And article, if it is there, you share it, okay, in the group.
Sure, sir. Yes, sir.
Yeah, okay. And you have read Bradley?
Yes, sir. And the clinical parts I have shared from Bradley and Kadilkar sir's book, sir.
Yeah. Kadilkar's Simplified Neurology, right? Which book? Kadilkar sir's.
SV Kadilkar sir Simplified Neurology, sir.
Yeah. Okay. Good, excellent. Excellent presentation, man. And imaging you have shown, treatment you have shown, genetics you have shown. You are not missing anything. Very good. Histology was good. And three-monkey model of cerebellum is one which we have to be remembered by the students. Very important clinical localization. And what is important is like peduncular lesions. What is the classical of peduncular lesions? You said so much. Do they cause dysarthria? Peduncular, superior and middle and inferior. They don't cause dysarthria. They don't cause cerebellar nystagmus. What they cause is they cause vestibular nystagmus.
Okay.
That is by inferior cerebellar peduncular involvement.
Yes, sir.
Okay, done.
Yes, sir.
Sir, someone is asking what are the tests other than dysrhythmia which you asked. What I asked was dysrhythmokinesis. Dysrhythmokinesis. Read about this. What is this? Dysrhythmokinesis. And rebound phenomena. And there is something called isometric ataxia. Isometric ataxia. Okay, these are the things which are discussed in the disorders of tests to be ordered in patients with cerebral disorders. Okay. Thank you, man. Thank you.
Thank you.
Okay, it was very nice presentation by Dr. Ramanan, and
Very
thank
nice.
you, Dr. Sheikh Afsar Pasha, sir.
Thank you.
And we will conclude the session.
Thank you.
Thank you everyone for attending this session.
Thank you.